So today is what? Today is the 27th, Monday at 11 o'clock. We're going to start talking about the hip. If you missed it and you hadn't seen it, there is a lecture up about general goniometry and general manual muscle testing that I posted. That was, I believe, Wednesday's lecture that I wasn't able to get online for. Just go ahead and review that. Most of the stuff that's in that lecture is going to be covered individually in each of these subsequent lectures. But just make sure you review it for the general understanding of goniometry and the general understanding of manual muscle testing. So each of these lectures that I do, when I go through each individual kind of joint surface, we'll have a brief re-overview of the anatomy, because obviously we've already seen that that's actually really good, right? Because some of the stuff you learn and some of the stuff is still kind of new to your brain. And then we'll kind of talk about how it applies with kinesiology. All right, so the hip itself, right? It's a ball and socket joint. It is multi-axial, but has 3 degrees of freedom. It is lacking the horizontal ab and adduction that the shoulder has, right? That's a unique motion in the shoulder, but it still has flexion extension, ab and adduction, internal and external rotation. When we talk about the open chain versus closed chain rule, right? It moves convex on concave in open chain, maybe when you're doing a straight leg raise or something to that effect. It moves concave on convex in a closed chain. So closed chain would be something like standing up from a chair or something to that effect. So you have to be paying attention when you look at your questions on your boards. You have to be paying attention to whether it's talking about an open chain or a closed chain activity, because that determines whether it's concave on convex or convex on concave. So the motions, again, we talked about. So there is flexion, extension, and hyperextension. So I'm going to caveat this here. Some books say hyperextension. Most books say that, where's my little drawer? There's my little drawer. Most books will say that this here is considered flexion, and that extension is anything past neutral going that way. That this is just return from flexion. So it varies based upon the book that's teaching you. But we will, according to this book, they go by the hyperextension rule. So we will talk about hyperextension with this. Hyperextension just has that negative connotation that a lot of times when we say hyperextension, people think, oh, going past or too far. Well, with the hip, it's not necessarily true. It does have ab and adduction, like I mentioned, and it has lateral, right, which is the same as external rotation, and medial, which is the same as internal rotation. And one of the key things to know when you're looking at lateral versus medial rotation is look where the knee is pointed. If the knee is pointed inward, it's medial rotation of the hip. If it's pointed outward, it's external rotation or lateral rotation of the hip. You have to get really good, though, in your brain of understanding that medial is this, lateral is that, because otherwise you get thrown sometimes when looking at those. So the bony landmarks. Oh, we've got the ilium. This is the fun stuff, right? So we're going to be dealing with a lot of the bony landmarks when we're talking about measuring. So we have our anterior iliac or anterior superior iliac spine. We have our fossa. What are fossas used for? What's the point of fossas in bones? Yeah, so something can lay in it, right? Usually muscle bellies. And we have our posterior superior iliac spine, posterior inferior iliac spine, right? These are the dimples on your butt, and these are just below it. We have our greater sciatic notch, which is really important because what do you think passes through that greater sciatic notch? Gee, I wonder. Yeah, the sciatic nerve, right? It'd be really odd if it like passed through the obturator foramen. Why do we have a sciatic notch then? Right? The ilium is eventually going to have a joint here with both the pubis and the ischium. And each of those have specific bony landmarks that go along with them as well, right? So the main understanding here is that the actual hip bone itself is really important to most of what we're going to deal with when we talk about the hip. So when we talk about the pelvis, that's traditionally what when we talk hip bones, The pelvis is the big part of the hip bone that we're always talking about. And we have our ischium here, right? We have our ischial spine. What's the point of spines and, you know, tubercles and stuff like that? What do they serve as? What's the point of spines and tubercles? Origin and attachments. Good, right? Yeah. Origin, insertions, attachments, and that's usually where the muscles will go to. We have our lesser sciatic notch down here. We have our ischial tube. And then in between the pubis and the ischium, we have our obturator foramen. What goes through the obturator foramen? What do you think? Does anyone know what goes through the obturator foramen? Okay, nerves, right? Which nerve do you think? I'll give you a hint. It's just like sciatic. So your obturator nerve, right? But you also have muscles, right? You have an obturator set of muscles that are part of your deep rotators that are in there as well. So those will go out there and then kind of exit out and attach onto your femur for internal external rotation of the hip. It's pretty rare, I'm going to say, that when we're measuring hip bones that we're actually coming down here and palpating, say, the ischial tuberosity or anything. The main thing you have to know are most of your bony landmarks are of your ilium. And of course, we're also going to talk then about the pubis, right? So the pubis is down here, and the pubis has the superior ramus, the inferior ramus. The pubis symphysis is where those two pubis come together and kind of merge together. They need to lay nice and neat with each other. Any shifting causes problems, right? And I've got a great, like I said, I've got a great picture from one of my exes where the pubis is sitting like this. That definitely is not a comfortable position, right? They should be, boom, on lock here. But it shifted so much that they actually shifted over each other. Your pubic tubercle, and all of those kind of combine together. The ilium, a little bit of the ilium, a lot of the ischium, and a lot of the pubis come together to form the acetabulum. And what's the point of the acetabulum? What is the acetabulum? Sounds bad, right? Sounds right what we're talking about. That's the acetabulum. Wrong. Yeah, right. So that is our socket for our ball and socket joint, right? So that we got to have both. Think about it when you're screwing in a light bulb, right? The acetabulum is the part that you're screwing the light bulb in, where that screw part is actually your femur. That's kind of the way I always thought about it. And then we have, excuse me, then we have our femur. We have the head and the neck of the femur. Right? And with the femur, we also have an anatomical neck and we have a surgical neck. Did Dr. Johnson talk to you guys about that? Okay, good. Right, and when we talk surgical neck, usually what we're talking about is when we are actually going to end up doing surgery on that femur. We have our greater and lesser trochs. The greater troch is one of our biggest landmarks we're going to use for measurements, because a lot of times that greater trochanter is going to be used as one of our rotational points. So it's going to be kind of our vertex when we're doing measurements of angles. We have the body of the femur, the medial and lateral epicondyle, right? That's terminating down at the knee. And then on those condyles, we also have the lateral and medial epicondyles as well. We have our adductor tubercle. Gee, I wonder what attaches the adductor tubercle. That almost seems like it's telling us right in the name. This is where a lot of our adductors are going to attach. Yeah. We have our linea aspera and our pectineal line, right? So both of those are just lines on the femur. And then we have our patellar surface, which is our actual, the area of the actual femur where the patella is going to articulate. Well, we're not going down that far yet today because we're going to talk mainly about the hip. So most of what we're going to talk about today, when we're talking about the hip, most of it's going to be this stuff up here, right? So let me move this down bottom here. I can set on my way. All of this stuff up here. This is the hip portion. This, right, this is primarily we're talking about our superior leg. And then down here, we're going to talk about our knee portions, which we'll talk about when we get into the knee. But a lot of this is what we're going to be dealing with when we're doing hip measurements and hip manual muscle testing. Lesser trochanter is not going to be used as much, right? But it is present. The greater troch, again, is our major thing. On the actual femoral head up here, what's laying over top of that femoral head? So what is this kind of off-white substance on the top of the femoral head here? What do you think that is? That's kind of laying over the, like a sheath over the head. Cartilage, right? Yeah, it's articular cartilage, so that when it's in that acetabulum, it's got a nice, smooth, articulating surface. And in that acetabulum, there's another layer of cartilage, right? To still allow nice, smooth movements. And you'll see when we get to the video how they kind of have to replace that, because they're going to have to put in kind of artificial cartilage so that when that ball and socket's together, you know, we used to do stuff like ceramics with total hip replacements. We actually had the ball and socket of the total hip was ceramic. The benefit to that was ceramics are really, really nice to articulate against each other, right? They have a nice, smooth, shiny surface, and they just glide so beautifully. And the total hip replacements, if you see somebody that's got one of those or had one of those, they'll tell you they really enjoyed their ceramic hip for movement, right? What would be the downside of using ceramics in the hip? Why would you maybe not want to suggest that? Sounds good to start with, doesn't it? Yeah, right? Ceramics, right? Anyone that's ever been in mom's kitchen moving stuff around, ceramics break, right? Or in a regular kitchen as well. Ceramics are solid, but they're not as solid. There are some companies that are out there. Johnson & Johnson is now looking at a carbon fiber hip, which I think would be really cool, but I can imagine that that carbon fiber hip is not going to be cheap, because carbon fiber is never cheap. Right, sounds expensive. Exactly. What is most, when we replace the total hips and we do those, what are we mainly making those out of nowadays? Titanium. Yeah, right. Two reasons. Titanium is strong, right? It doesn't break very easily. It is also a very hard metal. That means it's less likely to shave if it bumps any area that's not as smooth. Whereas if we do something like cast iron, or we do something, I would never use cast iron, that would be kind of silly. Stainless steel. Stainless steel can get little stainless steel shavings in there, and then you can actually get sick from getting metal poisoning in the blood. And the last thing we want to do is replace a hip and then kill them with metal poisoning. But you will see, if you watch late night TV, you know, or even during the day when it's morning and, you know, those game shows are on like right now, there's going to be commercials talking about, have you had a total hip replacement and then suffered metallosis? Please contact Sokolov Love, right? Because they're still going to try to make every penny they can. And yeah, and titanium's also not as heavy. That is a nice kind of benefit of it. All right, mesothelioma, yeah. I think what's his name? The big one here in our town. Oh God, why am I drawing a blank? Lerner and Rowe. I think Lerner and Rowe is now doing mesothelioma cases, which is fantastic. So we talked about this before briefly when we just kind of did the general overview of the body, right? The thing that we're going to be talking about when we talk about capsular versus non-capsular patterns is the actual joint capsule itself. Of the joints of the body, one of the tightest joint capsules you're going to encounter is the hip joint. The hip joint's capsule is really, really kind of, you've got muscles overlaid of ligaments, overlaid of muscles, and they just kind of wrap all around that head of the femur to keep that femur jammed into its socket. Because if it slips even a slight bit with how smooth everything is, it can just, you know, sublux and go south. So there's going to be ligaments here. We have the three main ones that are part of the joint capsule. Now, if you ever get a question on your boards that's asking you where these ligaments go or end, right, originate or insert, it's really easy to tell, because where they originate from is the first part of the name, where they insert is the second part of the name. So iliofemoral, what do you think is happening with that ligament? Where do you think it's starting? Starts in the ilium and goes to the femoral, right? Because that's the bone, the femoral. Goes to the femur. Pubofemoral, from the pubis, right, to the femur. And an ischiofemoral, from the ischium to the femur. And again, if you look at that, that covers all three bones of the os coxae, right? That is hidden from all three of those bones. That's going to provide a nice, stable kind of cross layout of the actual hip. And that's important. Now, if we go and look at creatures that are four-legged, that walk on all fours, these ligaments aren't as tight in them, right? They're just not they have a little bit more laxity to them. Number one, they're moving a little bit faster than us, right? If you ever try to catch a cat, you'll understand that cats move faster than us. But in general, we're designed for upright standing, so we need those ligaments. And you'll see this, and we'll talk about this a little bit in Therex when we talk a little bit about treating kids that have specific conditions like CP or muscular dystrophy. We have this term where they're hanging on their ligaments, and we talked about that with gait as well, where the person just kind of drops back and lets those ligaments around that hip hold them in place. Well, the downside to that is all that extra shear force is eventually going to kind of cause those ligaments to get a little bit lax, and it opens them up to bilateral dislocations of the hip. There is the ligamentum teres. What do you know about anything called a teres? What does that tell you? Because you have the teres major and the teres minor, right? Where else do you have a teres? So teres major, teres minor up here on the shoulder. And then you have another teres, right? There's 3 of them, good. And then you have another teres down here in the forearm. What's the teres down in the forearm? Pronator teres, good. Right? And it's a structure, right? It's kind of like the deltoid. The deltoid is fan-shaped or triangular shaped. Teres has the way it attaches is how it's named, right? So ligamentum teres, right, is a 3-pillared ligament. You have the acetabular labrum. This is probably one of the big things that gets injured a lot, especially in athletes, right? So you can kind of see a little bit of the acetabular labrum here. It would be this structure on the outside of that labrum. Serves 2 purposes. Number 1, it deepens the socket of the acetabulum, right? And the deeper the socket is, the better that femur is going to sit in there, the better it's going to hold in place. The other thing it does is because it does have a little bit of a wrapping function, right? It's really good friends with Dr. Dre and Snoop, so it's got a little bit of a wrapping function. I'm in Denver and I still got jokes. But it creates a little bit of suction there as well. So with that suction, again, it keeps the main goal of all of these is keeping that femur in there. Because we know as soon as we get it out of there, that's when we get problems. Does anyone in here have any tears in their labrum around their hips? I know I do. I have one in my right hip. I have a small tear in my right hip. Yeah, it's not fun, right? What do they do for labral tears? Well, what can they do? Well, a few places they haven't injured yet. Don't worry, you still have time. Yeah, pops a lot, right? So what they can do for it is they can do labral resection, where they go in and kind of cut part of the labrum out. But let's just think a little bit about that. Like there are a lot of studies that show it's similar to rotator cuff tears where, yeah, the surgery will help, but a lot of times guess what happens after the surgery? They're actually worse off, right? They told me that about mine when they said, oh yeah, you've got to tear your superior labrum. And the doc's like, well, I could do surgery. He goes, but you're probably going to come out worse. He goes, do you want the surgery? I'm like, who says yes to that? You're probably going to come out worse. I'm like, sign me up. Sounds good. I know you want the money. Right? You have your inguinal ligament. What's the point of the inguinal ligament? What is that? Yeah, then the point, right? The point is for them to make money. I mean, if you have a bad tear, it can be really useful to get that out of there because it's kind of like now every time you're moving, it's flapping around and getting pinched. And that's what happens with mine. I've got mine kind of pinches in the acetabulum and the femur, and that gets a little uncomfortable. But in general, I'd rather deal with that pain than thinking about having to have surgery. Inguinal ligament is responsible for forming kind of your groin, right? That's whenever you think inguinal, you think groinal region. And that ligament kind of makes sure that you've got that that anterior kind of structure, superior anterior structure of that capsule. And then you have the iliotibial band, otherwise known as the IT band. The abs connect there too. Yep, exactly. And that makes everything nice and tight, right? Because those are some of our tighter muscles. The IT band is going to go obviously from the ilium all the way down to the tibia, right? What muscle kind of helps attach to that or helps provide tightness to that? You have your IT band, which, yeah, the TFL, right? The TFL works with that. What is the point of the IT band? Because I always hear that a lot of people have problems with the IT band, and you're like, well, why do we have it? What's the point of that actual IT band out there? Yeah, it can, like, it forms that lateral border of the leg, right? And it does. It provides that again. It helps with that lateral support of the knee. And again, most of the time that we have problems, whether it's the hip, the knee, the shoulder, laterally is the way we go. We don't get a lot of medial problems. It's not like, I mean, some people will get knee buckling on the inside. A lot of our problems is that lateral, or what we call forming that L shape on the outside, right? So the varus force, where it kind of making that force very wide and opening those knees up. So the iliotibial band's a lot of lateral support of the outside of the leg, and then also down to the knee. But it connects the knee to the hip then, right? So that means if you have hip problems, there's a good chance you're going to have knee problems. Or if you have knee problems, there's a good chance you're going to have hip problems. It seems counterintuitive because that would be happening, but it's also because it provides that lateral support. So here we go, talking about kind of what our normal end feels, right? Normal end feel of all motions of the hip is firm, asterisk, right? The reason I'm saying that, so what is firm again? Do you remember what firm end feel means? Or springy end feel? That means if you kind of push on it and let it go, what's going to happen? Right? So firm end feels good at the wrist. If I pull back and let go, I kind of spring back. Yeah, right? The body doesn't like being in those firm end feels, right? If you take your hand right now and kind of push back here, the body doesn't like that very much, right? And it's to provide that sense of where the joint is. But also, hip flexion can be soft. Why might somebody get a soft end feel into hip flexion? What do you think might cause that? Okay, you put it a lot less, what do I want to call it? A little bit less politically correct than I would have put it. There's the term I wanted to use, right? Yes, but adipose for sure can cause us a, I know, that was nicer in person, I love it. Adipose, right? We also have a term for this, right? I don't know if you guys have heard of this term or if I've said it yet before, but there is a term for having too much belly adipose. It's called Dunlap's disease. Has anyone heard of that disease before? Where your belly Dunlaps over your belt? It's not a real disease. I'm joking. It's a joke. That's a joke, right? Dunlap's disease. That's something we suffer from quite frequently as human beings, where it'd be better not to. Why else might you have a soft end feel? What else? Oh my God, I was Googling. That's fantastic. All right. What else could cause you to have a soft end feel? What if you have big quads? Fluid, definitely. Oh yeah, there's one. Especially if you got, end-type lymphedema. But what if you got really massive quads? Couldn't that also cause a little bit of a soft end feel? Right? If you get up there in those big quads, right? People that don't skip leg day, get up there. Yeah, that could cause it. But a lot of times, people that have those really big quads, when you try to move them in the hip, you'll find out that you're not going to move them anyway because they have no range of motion. Right? One of the strongest parts of my body, I know from fact, is my legs. My quads and my hamstrings are amazingly strong, and I've made them that way because my knees are really bad. And so I've really worked my quads and my hamstrings up. The downside to that is working them and making them super strong has made them super tight. So like my hip range of motion's gone. Yeah. Okay, shorty shorts would be a good one too, right? Daisy Dukes would definitely limit your range of motion. Well, I guess Daisy Dukes wouldn't so much limit your range of motion into flexion, but it'd probably limit it into extension, I'm thinking. Yeah, bike shorts could do it. There's anything that could cause it. But most of your motions, right? So if we go into external rotation, it's going to be firm. If you go into internal rotation, it's going to be firm. Go into extreme flexion, most of the time it's going to be firm, right? If you get somebody tiny, especially, you get them up into extreme hip flexion, those extensors that are on the back that are all lengthened out don't like that, and they get kind of angry and they really spring back. Even extension. Extension is going to be the hardest for a lot of us when we actually do the manual muscle testing and the range of the motion. Because when we get back past neutral of the hip, a lot of us will cheat, right? So, when you're standing up here and you're going back, a lot of us will start doing this just because we're so tight in the quads. All right, so looking at some of the muscles of the hips, right? This is what I'm going to say. you have to know your origins and insertions. So you have to know your O's, your I's, your A's, your N's, and your NR's. But if you understand about where they start and about where they end, you can usually answer most questions. So maybe you don't know what the exact origin of psoas major is, right? You don't remember which ribs it comes, or which spinal bodies it comes from. That's fine. If you know it comes from the lumbral spinal bodies, you can usually go down to the question, the answers, and figure out which ones are, narrow it down to 2 answers, right? It's not like you're going to hit a lot of them that are going to be like L1 and L2, L2 and L3, L3 and L4, L1 through L3, L4 through L1. No, it's going to be specific. There's usually going to be 2 of them that are related to each other. That'll say something like L1 to L2, L3 to L4, and the other 2 will say something like the sacroiliac joint and the shoulder girdle. Well, psoas major doesn't attach to either of those, right? So you can get it down to those 2, and then you can kind of figure out which one's the right answer. What I'm saying that for is, you know, you don't have, when you get to the test, you don't have to specifically remember every specific hardcore origin insertion. Knowing that will really help your chances of answering questions when you get those level 1 questions asking about that. But at least in the head, if you can go, okay, so it starts about here and it goes to here, that's a huge improvement. That can be a huge thing over other people. And the way I got that was I palpated on a lot of people. I'm talking a lot. You know, I went down with my flashcards for my muscles, and I said, hey, can you lay back? I want to go through the leg muscles really quick, and I want to palpate the locations of them. Because there's something about seeing it, right? You can pick up those flashcards you guys all, either you made or you bought, right? And go, biceps brachii, long head origin, short head origin, insertion. You can just brain through that. But there's something about going, oh, okay, so, okay, yeah, okay. There's something about getting hands-on that really kind of clicks that in with you. And in the clinic, I'm going to say, if you go out to the clinic right now and you ask somebody what the origin and insertion of the sartorius is, if you ask 50 therapists, PTs and PTAs, how many of them do you think would know the origin and insertion of the sartorius? What percentage do you think? Yeah, maybe half, maybe one. Yeah, why? I'm forced to, unfortunately. You know, when you guys have the anatomy, I don't think you realize how much of a challenge it is for Dr. Johnson and I, because we don't talk about the origins and insertions all the time in the clinic, so we have to go back and reread them too. And you'll find Dr. Reskin and Therex will mess them up all the time. And just don't call Dr. Reskin out. Just nod your head and correct her privately. Don't go, hey, I think you got that origin wrong. Just warning you in advance. Hello, buddy. So, you know, where was I going with that? The cat distracted me. So when you're working on that, just make sure you have a general idea where they come from. The main ones I would make sure you do know are the nerves and the nerve roots. Now, do you have to get really specific, like, is biceps brachii just the lateral cord of C5, C6, or is it the anterior or the posterior cord? No, just knowing that it comes from about C5, C6. Yeah, the cat popped in and ran away again. I don't know where he went to. He came to listen about the hip. So I just want to let you know, don't totally freak out if you guys don't remember everything, okay? Knowing general facts can help you get through it. And I'm sure that a lot of you actually, well, I won't say a lot of you, some of you got through some of those questions on the anatomy practicals by going, not quite sure, but this sounds right, right? So muscles of the hip, on the anterior side, we have our iliopsoas, right, which is our iliacus and our psoas major. We have our rectus, darnioculatus femoris. And then we have our sartorius, right? We will be sartorius. All of those kind of form the anterior capsule, or the anterior muscles covering the capsule of the hip. Most of those will have some job or some part of flexion, right? Most of those will bring those legs upward. And then our medial line, we have our pectineus, right? Which is going to go to the pectineal line, obviously. We have our adductor longus, brevis, and magnus. Which one of those is the biggest of the muscles between the adductors? Which is the biggest, okay? Which is the longest? Gee, that's really, and then the shortest would be the brevis, right? It's nice how they enable that for us, right? And then we have the Gracilis again, which if you follow all the way up goes to Graceland, where you may meet the king or queen. That's the way I always remembered that one. So here's our adductor muscles, right? And then we're gonna come down here. Now we get to the posterior core, or posterior part of that hip. The main thing back there on the posterior side is gonna be our glute max, right? That's our big, broad hip extender. And it is very useful. Obviously, it provides us with cushion when we're sitting every day, right? We're sitting here now, we're all sitting kind of back on our glute maxes a little bit. We have our deep rotators. There are 6 of them. Again, I will talk about certain ones of them. I'll talk about gemellus superior, gemellus inferior, but your boards aren't going to specifically ask what the origins and insertions of gemellus are. If you're a PT, absolutely they will. But PTAs, we kind of get a break on knowing all the rotators individually, but we do have to know that there are a total of 6 rotators that are deep, so that means they lay under all the other muscles of the hip. You have semimembra and semitenda, right? And then you have your biceps femoris, the long and the short heads. All those make up the posterior capsule, or posterior part of the hip. So here's all of those deep 6. Obturator internus, obturator externus. Piriformis, that one I would suggest kind of learning because piriformis comes into play heavily. You have your superior and inferior gemellus, and then you have a quadratus femoris. How many of you guys knew all of those muscles were part of the deep 6? Did anyone? Nope. Did you know at least one of them? Hopefully. Good. All right, at least we know one. Right. And looking at this, their job is to make sure that hip does proper rotation. And the gemellus group is a lot like your, what do you call them? The muscles in the mid-back. Oh my God, I'm drawing a blank. Why am I drawing a blank? I forget where I was going with it. But the gemellus and the obturator muscles, although we label them as different, they have slightly different origin insertions, they do the same thing. So it's really hard to separate them out. Even when you're doing a dissection of the cadaver, it's really hard to figure out, is this fiber gemellus superior, or is this gemellus inferior, right? Piriformis is going to be one we talk about pretty extensively, though. Because does anyone know what goes right there? Actually, technically goes right there. I drew it the wrong way. Yeah, your sciatic nerve, right? So your sciatic nerve, and sciatic nerve can go a couple different ways through piriformis, right? So let me get my little drawer up here again. Get a different color. Let's get blue. I like blue today. So here's our piriformis muscle, right? It's kind of triangular shape or pyramidal shaped, hence piriformis. And then we have our sciatic nerve. I'm going to make the sciatic nerve red because it's usually angry. It was angry coming here. So it's going to pass underneath your piriformis. So now, if you have a really tight piriformis, what's that going to do to the sciatic nerve? Pink hit it, right? It's going to pinch it. Yep, you got it. I like the pink hit it. That's fantastic. It's going to pinch it, right? Now, that's most of us. Now, some of us have a sciatic nerve that actually goes over top of the piriformis instead of going underneath it. That kind of sounds better, doesn't it? That way we don't have to get it pinched by the piriformis. It's right on top. What might be the problem there if it's over top of the muscle now? What do you think the muscle provides it with? Well, just think, now that's laying over top, you can actually palpate your piriformis. And now you go to sit down, and that direct force is going to be right on that sciatic nerve now. There's going to be no cushioning. Ouchie, right? That could be painful, just saying. Let's delete this and get a different color here. And then we have the really fun people. Again, another small group of people have a piriformis that starts underneath, kind of hitches up in it through, and then comes back down and underneath. So it kind of does a stitch through the piriformis. Now we've got a little bit of exposure plus tightness that could cause problems. So there are 3 main different types of piriformis. There's no way you're going to know what the patient has. You can't look at a patient and go, well, I think just by looking at you today, Bob, you have a type 1 piriformis. You can't. even on a lot of our MRIs and stuff like that, it's really hard to tell. If somebody's really sensitive to sciatic nerve pressure, a lot of times they are the type that lay over top, but it's going to be anecdotal. We're not going to be able to specify it out there. The piriformis is probably one of the muscles in physical therapy as a PT and a PTA. You want to make sure that you have strong, but also very, very limber. Because if you don't have that nice and kind of flexible, then you're pinching down on that piriformis, and every time you transfer a patient, it's going to let you know, right? Because you're going to tighten your butt up to transfer that patient, and that means you're going to tighten that piriformis down, and all of a sudden that sciatic nerve is going to say, hello. And you're like, all of a sudden, the back of my knee hurts. Talked about the posterior muscles already, kind of went through those. Lateral muscles, the main lateral muscle we have is our glute med. We do have a glute minimus as well. And then our TFL, our tensor fasciae latae, right? But understand that TFL is a very, very tiny muscle, and the glute min lies inferior or underneath your gluteus medius. There's our TFL. Look how tiny that TFL is. It's a itsy bitsy muscle, right? But man, can that cause all kinds of havoc with runners, especially if you're female. Structural variations. Now we're going to start talking about the actual structure of the hip and how it can change. So we have two different types. We have anteversion and retroversion of the hip, okay? And this is talking about the way that the femur actually looks in the socket and the angle that it forms from the neck into kind of the condyles, right? So if you're anteverted, the femoral neck is going to lean more forward, a little bit more anteriorly, right? So that is why it's anteverted, leaning forward. When you have that anteversion of your hips, it's going to result all the way down the legs to toe in, where your toes are going to be pointed in when you walk, right? Retroversion is the opposite. Retroversion is where you are pointed towards the back. And if you're pointed towards the back, you'll end up with toe out, where you're walking like Mr. McKeever walks all the time, with his feet turned completely sideways, right? A normal person kind of has just, there's not a specific term for a normal hip. It's just a normal hip where feet are pointing straight forward, blah, blah, blah. Now, can you adjust for those? Absolutely. You can force your feet into walking normal and stuff like that. But if you've got a retroverted hip or an anteverted hip, it feels uncomfortable. And again, because of the way the femur is shaped, it's not like we can give them an orthotic and reshape the femur. The femur is shaped pretty much once you've hit 18 years old and gone through puberty and gotten through most of your development. It's not like you're going to reshape your femur. It doesn't happen that way. So again, anteversion, the femoral neck leans forward, so it leans anteriorly, and you result in toe in. Retroversion, hips lean backwards, results in toe out. Does that make sense to everybody? Are we good on that? Cool. All right, moving on. So now we're going to talk about coxa vara and coxa valga. Have you heard the term coxa before? Where have you heard the term coxa? Coxa literally means what? Hip. Yeah, ox coxa is your hip bones, right? Good. So coxa vara and so we have the angle of the femur pointing forward and pointing backwards. We also have the angle of the femur going this way from down that femoral neck, right? So coxa vara, right, is a femoral neck that sits closer to 90 degrees. So in all of our bodies, we have this what's called angle of inclination. And the angle of inclination normally, for most average ordinary persons, is about 125 degrees. Okay? So if you have coxa vara, the angle is going to decrease. If you have coxa valga, the angle is going to increase. So and the way that I remember this is the only way I could remember this one in the hip was Coxa vera is a very small angle. Even though 90 degrees isn't small, it kind of reminded me in my brain that it meant less than our 125. So if you see a patient and they talk and you look at their x-ray or their MRI report and it says that their angle of femoral neck inclination is 85 degrees, that means they have a coxa vera problem in the hip. And this can happen for many reasons. It can happen from being taught poorly to walk as a child, or it can just be because that's the way you're born, right? You were born that way. The vera results in a decreased angle, and then it will create greater shear forces on the femoral neck. So as you're walking, if you think about it, the flatter this angle is, the more force is going to kind of cause that to kind of, so you've got the angle like this now. Every time you walk, this is really getting pulled really hard. And it creates a lot of shear forces on the neck. And a lot of times, if you have coxa vera, you're going to end up eventually having a hip replacement, just because it's going to wear out over time. When you have the coxa valga, the neck sits greater than normal angle, which creates greater stresses directed through the femur. And what that means is now you're here, right? So this isn't as much of a problem, because it's really hard to transfer forces at 150 degrees. But the other downside of that is the ground force. So all that force coming up through the femur is not going to get shared up into the main hip area and the back to help cushion you. And so all that ground force is going to be redistributed either into that actual the femur itself, the femoral body, or into the actual acetabulum, which is going to lead to breakdown of the acetabulum. A lot of times when we have patients that need hip replacements due to acetabular breakdown, they usually had coxa valga, where if they have it due to femoral neck fracture, they had coxa vera. Now, when they go in and fix you, they do a total hip replacement, they're going to put your angle of inclination back to 125. Now, just imagine you've gone through life at, say, 90 degrees, and then suddenly you snap your femoral neck. They go in, they replace it, and now you're at 125. What's that going to feel like? Is that going to feel weird? Yeah, it's going to mess up your whole gait, right? You may have to learn to walk all over again, because now that's going to lengthen the leg a little bit, right? So if I'm here, I'm going to end up with a little bit shorter of a leg, right? Now it's going to lengthen my leg a little bit. It may throw everything off. And sometimes what happens is funny, is a patient comes in with a short leg, they go out with an even leg, and now they're going, this doesn't feel right. Why does it feel so weird when I'm walking? Well, it doesn't really feel weird. You just didn't know you were wrong in the first place. Now you feel normal, and you're just not used to it. So those two, so you have either that angle of inclination, right? Or we have the pointing of the femoral head. So either of those can happen. We cannot fix those through stretching of soft tissue, right? It's not like if a patient has coxa vera, we're going to say, well, if we do a bunch of anterior hip stretches, we can get that fixed. No, that is a structural abnormality. When you have structural abnormalities, the only two things you can do is either deal with it, meaning maybe put some orthotics in or something to that effect, or structurally repair it via surgery. There's no way you can actually just go in and go, oh, well, let's stretch that bone out, right? There are some theories out there, if they catch it early enough on in childhood, that they might be able to do traction on the limb in order to cause it to actually kind of even out, because our bones are still green when we're kids, right? But the actual outcomes of it aren't that great. So if a patient has something like a coxa vera problem, but they have no symptoms, is that a pathology? What do you guys think? So what if I have coxa vera on my left side, but it doesn't affect the way I walk? From purely medical standpoint, yes, it's a pathological condition, right? From my standpoint, if I have that and I have no pain and I have no problems, I'm going, what are you talking about? I've never had problems. Now you're trying to fix me, and now it's getting worse, right? And this happens a lot of times. We'll notice that a patient has low back pain, and we work on the low back, and we work on the low back, and we work on the low back, and we work on and we get nowhere. And then we take a look at the hips and realize, oh my God, they've got coxavera on one of their hips because one leg's shorter than the other. And now we put an orthotic in to even that out. Now the patient goes, well, you know, my back pain feels better. God, my hip hurts now. Why is my hip hurting? Well, because reality is that was where the pain was to start with. That was where the problem was, right? But what we've just done is transfer it to where it should be, and now the back feels better, but the hip feels weird. And a lot of times with orthotics, it's going to take 8 weeks till they really get used to wearing an orthotic. It's not fun. So if that is causing pain, if it is causing decreased mobility, then we need to address it. If it is not impairing their function and there's no medical reason to adjust it, we should just leave it alone, right? Again, the labral tear I have in my hip still functions. I'm still able to kick above my head. I'm still able to walk. Does it cause me some pain every now and then? Absolutely, right? But not enough to keep me from moving around. At that point, there's no point to fixing it, right? Change that subject, because I'm just using this as an example. My neck, when I fractured my vertebrae. When those vertebrae got fractured, that can eventually lead me to paralysis because those bones could shift, pinch off the cervical, the spinal cord, and then I lose all motion. That is a medical condition that should be addressed. Same idea at the hip here. If the dysfunction is not, if the structural variation is not causing problems, leave it alone, right? Maybe work on some muscular energy techniques where we're doing different stretching and strengthening of the other muscles, but don't send them off for surgery if they don't need surgery, is kind of what I'm saying. So we'll come back to this. This is the total hip replacement. So I'll come back to this and we'll watch this in a few minutes. So I just want to kind of go through. This is kind of what it looks like when you get a total hip replacement, right? And this is, yeah, you're like, whoa, right? And in this one, this is probably more of a rod and pinning than it is a pure total hip replacement. And I think actually this is a lateral fracture of the femur, if I remember correctly. It's been a while. I forget who I got this from. But you can see the nice screw going into the bone up there. That doesn't look very comfortable. And all these pins going through the femur. And a lot of times patients can feel those too on the inside. It's fantastic. Right? This is why I said if you get a chance, when you guys go out on your clinical affiliations, if you get a chance, try to go sit in on a surgery. It will change your appreciation of the pain the patient comes out in. Because when I first started working in orthopedics and I was in the hospital, I'd see them come out of total hip replacement. Yeah, you can absolutely. You can ask to. You just ask your PT if you're in an inpatient setting, hey, is there any way I can go down and watch some orthopedic surgeries? And they'll hook you up with one of the orthopedic surgeons and send you down. I saw a total hip, a total knee, a lumbar fusion, and then I also saw a heart replacement. And all of those were so cool to me, right? Yeah. Now, if you have a weak stomach, maybe think differently. But if you can get a chance to see it, it's really cool. Because when I went down there, I went in thinking that, first one was a total knee that I saw. I thought going in, well, this is a really surgical procedure. But in reality, a total knee replacement is more carpentry than it is surgery. They started laying the tools out for it, and there's like a mallet, a drill, an awl, a burr grinder. And I'm going, are we doing surgery or are we putting up shelving? Because it looked like we're doing shelving. It is. They're really cool to watch, aren't they? I will warn you, if you have a morbidly obese person, maybe think twice about going and watching a total hip replacement. Because that was kind of disgusting. The one I went for that, the lady that I went to for my total hip replacement was about 700 pounds. And that was why her femur fractured, obviously, is because of weight. But the doctor literally had to take basically a melon baller and go in and scoop out the adipose in order to get to the bones. I mean, it's the best thing. I'm sure it's not a melon baller from the kitchen, but it looked like an ice cream scoop. So here's your traditional total hip replacement, right? So this one has an acetabular component as well as a femoral component. So the term for a total hip replacement is a total hip arthroplasty, a THA. THR is just a common term we use. Now, if you go to the East Coast, I'm going to warn you. When you see THA, it typically means they had a hemiplasty, meaning that they've had half of their hip done. So they either replace the femoral component or the acetabular component. A THR is a full replacement. It's changed out here. We're on the West Coast. I've had to get used to that because I'd see somebody put across a THA, and I'm thinking, oh, it's a hemiarthroplasty. But out here, we actually call them either THA. They're both THAs. We either call them a hemi or a full THA. So it just depends upon where you're at. Sometimes that terminology can be a little bit weird, right? But in a total hip replacement, we have the ability to do that. We have the ability that if the patient's only problem is their acetabulum, we can go in, pop that hip out of socket, go in there and grind all that stuff down that's in our way, put a fresh pop socket in there, and then pop that hip back in, and away they go. And they're all happy and in pain. If they just need, maybe they broke their femoral neck, we can just replace the femoral neck and leave the acetabulum alone. But understand, just think about that, right? It's just like your car, right? Say you've got one tire that the tread's a little worn out. And so you decide to replace that one tire. Sooner or later, you're going to have to replace the others, right? Or, you go in and one of your brakes is more worn down than the other. You're like, oh, I'll just fix that side. Well, eventually the other side's going to wear out anyway, so you might as well change them, right? Headlights are an excellent example of that too, right? I never understand why people replace one headlight bulb. If you're going in to replace headlights, you might as well replace them both. Same idea here, right? And so there's those pros and cons benefit here of, well, if they only replace half of it, we know sometime in the future they're going to have the other half replaced. The gamble there is, well, maybe they'll die before we do the other half, which is not much of a gamble in my opinion. I don't think that's a nice idea. I will say from experience, I have better results with patients that have total hips than total knees. My total knees are usually my biggest babies. And somebody that has the hip replacement, which you think this would be the worst one, right? Yeah, you see Michelle agrees. And especially if it's a male 40 to 50 that has a total knee replacement, just get ready. They're usually pretty babyish. But in this case, and again, generalization, not specific, but generalization when I've seen it, most of my total hips are rock stars. They usually do more than they should. Whereas my total knees, I have to kind of beg them and plead with them to actually work. So, oops, what happened here? Does anyone see a problem? Yeah. So what kind of a dislocation would this be? It's going to be named for the way it went. So which way did this hip go? Superior dislocation. Yeah, so it's a superior dislocation, right? And these things back here are not worms. I had somebody say, are those worms in the person's hip? No, those are the screws holding the acetabulum in, right? They're actually going into the os coxae and holding it in place. So I like to sometimes show some of my patients that don't follow hip precautions this picture, because this is from a patient that didn't follow his total hip precautions. And if you don't follow your total hip precautions, your hip can re-dislocate. Because think about it, yeah, it does work as a good scare tactic, right? They have to dislocate your hip in order to do this surgery. If they don't follow the precautions, they can re-dislocate the hip. So they have to be paying attention. We're going to talk about those precautions in a few minutes here about how they get a little different, right? So actually, I'm going to do that now. So let's talk, what are our 3 types of total hip replacements we can get? Does anyone know? There are obviously all THAs, but there are 3 types because they're good. So they're named after the direction they go, right? So we have our posterior. If we have a posterior, guess what else we have? Anterior, good. And we have one more. Lateral, or it can also be called anterior-lateral. So those are your 3 main types of total hip replacements. The most common is your posterior. And the reason why that one is the most common is because most people learned that in school way back when they started doing surgeries, right? It's been the most commonly done. With the posterior hip, though, the sad part about the posterior hip is it requires a lot more cutting into that joint capsule that holds the joint nice and tight. So a lot of times those are going to have the most restrictions, and the restrictions will last the longest, right? This is kind of this, and this is where we get, you have to understand your doctors when you do that, because some doctors will call an anterior hip. Some of them will call the anterior lateral. So you have to understand when they're talking about it, do I have precautions? Do I not have precautions? And that's the main differentiating thing between an anterior and anterior lateral. So they're going to be named. So, and if you need to find the surgery scar, you're just going to look where you're looking, right? So if I have a posterior hip surgery, it's going to be in the butt. If I have an anterior hip surgery, it's going to be up here towards that ASIS. If I have an anterior lateral, it's going to be out here on the side. Makes sense. Does anyone know what the precautions are for a posterior hip? There are 3 of them. Okay, so I got no adduction, good, no internal rotation, and don't pick things up. Yeah, no flexion, right? So no flexion greater than 90 degrees. No internal rotation past midline, and no adduction past midline. So a neutral leg is okay, right? So pretty much the leg in neutral. Now, does that mean we can't flex at all? No, it just means that we can't bend way far over, right? So you have to take these and get them into a word that the words the patient will understand. So no flexion past 90 degrees. I always tell them no bending way far over, nose over toes, right? No internal rotation past midline. Don't turn your toes in. No adduction past midline. Don't cross your legs. The patient that you're looking at here was sitting in the chair with his legs and everything totally crossed and internal rotated and in extreme flexion. He went to move and booyah, right? That just completely dislocated. No bueno. So if that's our posterior hip precautions, what do you think our anterior hip precautions are going to be? Well, anterior is going to be the opposite. So for the anteriors, we're going to have no extension past 0. I tell them 0 degrees, but a lot of times it's 5 degrees by the doctor. If I tell them 0 and they go to 5, I'm okay, right? No external rotation past midline, and then no abduction. And usually it's greater than 30 degrees, because we still have to have a little bit of abduction, but it's going to depend on surgeon. Some of them will say no abduction, period. Right? So you have to make sure you understand your precautions by your surgery. Right? So no going way back, no putting your leg way behind you, no turning your toes out, and no spreading your legs. That's what I kind of tell my patients when I have that. And then we have kind of our, what I consider kind of my gold standard, I would prefer, gold standard. Does anyone know what the precautions for the laterals, the anterior laterals usually is? Usually. Does that make your job easy as PTA? Typically on those anterior laterals, there's usually no precautions. Now, some surgeons will still adhere to the anterior precautions with them, just because they still want to make sure of it. But literally, if you think about these, where that surgical site tells you what they have to avoid, right? So if my surgery site's back here on my butt, if I bend my hip way up, I'm putting a lot of shear force back there where that surgery site was, right? If I turn my foot in, again, I'm really putting a ton of shear force on that surgical site. And if I bring it across midline, a lot of shear force on that surgical site. So understanding the precautions are really easy to understand once you kind of think about where that surgery happened at. Does that overall make sense though? All right, I'll just leave these up in the corner in case people need to write them for now. Open pack and closed pack positions, right? Open pack is where we do mobilization. Closed pack is where we have stabilization. So for an open pack position of the hip, we're going to be in about 30 degrees of hip flexion, 30 degrees of hip abduction, so slightly out to the side, and slight lateral rotation. And then closed packed is where we're fully extended and turned inward. And you think about that, if you do that, right? So if you're standing up and you extend your hip way back and turn in, you can feel how tight that hip jams into that socket, right? Whereas the open pack position is going to be about here, here, and here. And that's where we can actually mobilize. The main reason you need to understand that is when we get into joint mobilizations, you have to be able to put them into that open pack position, right? So a lot of times when I do joint mobilizations of the hips, I bring them into slight hook lying and just kind of let the leg fall out to the side. Now that hip's in an open pack position where I can mobilize it really easily. If they're in full extension, it's really hard to mobilize that hip. Now, whether the patient has a capsular appearance or non-capsular appearance of the hip will determine upon what they look like. If the patient's problem is the hip capsule and not the muscles or structures of the hip, they're going to have really reduced medial rotation with combined flexion and abduction. So they're not going to be able to turn inward, flex, or abduct their leg. Or worse yet, they're not going to be able to do all three of those together. And when we do PNF patterns, one of our patterns will kind of test that. If they're limited in all three of those, that's the capsular pattern of the hip. And why I'm saying that is because capsular patterns are really easy questions to write on for your boards. So you do have to understand your capsular patterns, right? That means that that actual capsule, all those ligaments holding it in place are the problem, not the muscles and the bones per se. If the patient is just limited in medial rotation but has normal flexion and abduction, that's not a capsular problem. At that point, it's probably muscular, and we have to look at it that way. Does that make sense? So in order to have a capsular pattern, you have to be limited in all three of those ranges of the motion. So medial rotation, flexion, and abduction. Full range of motions of the hips. This may surprise some of you. So for full range of motion of flexion, you have to have 120 degrees of hip flexion. I guarantee most of us are short of that, right? And we're also going to probably be short of extension, again, because our quads and our hammies are really tight. Usually ab and adduction we're usually okay with. Those usually we get away with and have fairly normal abduction and adduction. We still may see, so if the person probably has more abduction, they're probably going to be limited in adduction. Again, because that tight versus loose muscle feeling. And then medial and lateral rotation, again, 45 and 45, but we're going to find that when we test each other, when we get back to the lab, we're going to find that we're dominant in one of those. We may have, 55 degrees of medial rotation, whereas we only have 15 degrees of lateral rotation. And it really will come into play when we get up here to the shoulder and we see that, oh, we got great external rotation, but man, our internal rotation sucks. It's really common for the opposite to happen. So if I have really good flexion of the hip, I often have poor extension. If I have really good abduction, I often have poor adduction of the hip. These are the numbers you're going to have to know for your boards and for my tests. So these are the memorization part of kinesiology, understanding the numbers as they stand for motion. So while we have, so this, right, I'm going to get rid of this stuff over here to the side real quick since that gave you plenty of time. So when we are documenting on patients, if they have these, right, if they have all those, they are considered within normal limits, right? So within normal limits. Most of us, when we test each other, we will not be within normal limits. Does that mean we can't get around? No, because the next thing we're going to look at is, are they within functional limits? And that's the next slide here. So these are our normal limits. These are our functional limits, meaning what do we need to function? So in order to function, we have to have about 30 degrees of flexion, 20 degrees of extension. That makes sense. We need room for heel strike and toe off. To go up and down stairs, we need about 60 degrees of flexion in the hip. And ideally, we need to get to at least minimum of 0. Maybe not have any hyperextension or any extension back there, but we definitely need to be at 0. Does that mean if you don't have these, you can't go upstairs or you can't walk? No, it just means that your gait and your ascending and descending stairs are not going to be functional. So for your boards, I'm going to say that this gets a little difficult remembering the difference between functional and normal limits. So for these, when I'm studying for my boards, I pick numbers that are close to each other. So I'll say that for functional range of motion, walking on level surfaces, I need 30 degrees of flexion, 30 degrees of extension. Even though that 30 degrees is 10 degrees over the 20 of what we need by the book, they're not going to have a question when they ask you, so what do you need for extension for walking on level surfaces? They're not going to say 21 degrees, 20 degrees, 19 degrees, 18 degrees. What they're going to say is 60, 90, 45, 20. And what you need is 20 for walking on a level surface. The good news for going up and down stairs, the flexion's the same, 60 degrees. That makes that fairly easy. So we're going to go through, you have a couple books, or you should have most of your books at now. For manual muscle testing of the goniometry of the hip, manual muscle testing of the hip, we're going to go through those. Those come from the Daniels book. For goniometry, they come from the Norkin book. So both of those books are spiral bound. When we get back into class, I'm going to be talking about your hard-bound spiral-bound book and your soft-bound spiral-bound book. Your soft-bound is your goni book. Your hard-bound is your manual muscle testing. Doesn't matter what we're doing, whether we're doing manual muscle testing or goniometry, even though it says down here goniometry, we have to know our landmarks. So our landmarks are going to be really key to both stabilizing and making sure we're getting accurate measurements. So we're going to measure, when we actually go through goniometry of the hip, we're going to measure hip flexion, hip extension, hip abduction, hip adduction, internal and external rotation of the hip. We're also going to do manual muscle testing for all of those. For each of those, there is a preferred position for manual muscle testing that is going to be against gravity. There's also going to be preferred positions for gravity reduced or gravity eliminated. There are some other tests we're going to go through when we get towards the end of the class, especially when we get back to lab. We're going to run through some special testing where we do the Thomas test, the straight leg test, the Ober test, and the modified Ober test. And with those, what we're testing is, do we have a tightness or a shortness in one of our muscles? So again, I talked about the manual muscle testing. And again, we will practice these in a sec, or when we get back to class. There's not an easy way to practice. So for right now, what I would suggest is learning your norm values, learning what you need for what within normal limits is at the hip for flexion, what the functional limits at the hip for flexion is. If you can get those, that will help you prepare for when we get back to class and physically start getting hands-on with people. Because that's going to be the big thing, is once you kind of learn the norms, and you start feeling, oh, well, this is how we do it, then it'll make sense. All right, I think I have 15 minutes. I can go through that video real quick. And give me 1 second. I'm going to stop this screen share so I can bring up the video. I think the video is about 10 minutes, and then I'll cut you guys loose. Let me see here. The video is 10 minutes. All right, so let me re-screen share here. Do I have that separated out? Let me separate that out. All right, so screen share the video. All right, so wait, I gotta share my sound too. I just realized I didn't do that. Stop share, because we need sound as well. Share screen, share computer sound, share, there we go. Now I got it right. All right, can everyone see the total hip replacement on screen?
Yes.
Cool, all right. So we'll watch this. I'm going to put myself on mute just so I don't kind of give you feedback on this, but we're going to watch through most of this. I may speed up a little bit, but here we go. Get ready to get a little nauseated. So what do you guys think? Doing good until the cone part? It's really cool, right? I mean, when you see it, that's my thing. It's amazing that we can do that. So each of those parts you saw, like you saw the rasp and you saw the lathe and you saw all the parts they're using, they're all designed specifically and they're angled very specifically. So when they ram them into the bone, it does make you feel a little you're like, oh, you guys can do this and I can't figure out where the gluteus medius actually is. It does kind of make you feel that way, right? But they're all designed specifically for one specific part of it, right? It does, yeah. What was that really thick, gooey red stuff that was coming out when they were pounding the components down in? Does anyone know? It was marrow. Yeah, they're pounding the marrow out of the bone. So the actual structure, so that actual femoral component that goes down in, and even the acetabular component, will either go in with pressure. When they put it in, it just basically gets jammed in there like you jam in a good hard nail, or they'll put a thermoplastic cement with it. And I'm going to give you this warning: if you ever go to a surgery and view the surgery, and the doc says, "Here, can you?" and you'll have gloves and mask and everything on when you're in surgery. Can you work this cement a little bit so it's ready for when we go to put it in? They'll tell you to squeeze it between your hand a lot. Don't do that. They're tricking you. Because the cement is a thermoplastic compound that, with movement, heats up. So that it'll eventually set nice and hard. So as you're sitting there working it, thinking that you're doing something good for the surgery, what it's really going to do is it's going to burn your hand. And then they're going to laugh at you. Doctors are cool. Or at least orthopedic surgeons, right? They've done it. They did it to me. I was just a total. I'm like, ooh, okay, work it, and I'm like, ow, and he laughed. But it's really neat, right? Just looking at how the fact that they literally can go in and go, okay, so this is glute med, okay, this is glute min, so I need to separate them out. You know, how they cut down the actual side of the leg, and really, I mean, why did you not see a lot of blood there? Why was there not a lot of blood going? And there was some, but there wasn't a ton. What did they do? They suction and they tourniquet it off a little bit, right? So they're going to cut off blood flow just a small period, right? And cut off just long enough so they can get in and get the surgery. And you saw that 10 minutes. That wasn't sped up. That wasn't 10 minutes. They were in, got the bone out, put the component in, right? And then we're out. And guess what? They're probably on to the next person. They probably went from that surgery room through a scrub room and right onto the next total hip replacement. That's pretty impressive, right? So now remember, what is that? So as far as the device goes, so that the total hip component, so the femoral component, the acetabular component, those are now prosthetics, right? Because those are parts that we put to replace natural body parts. Afterwards, we may have to put them in a little bit of a hip brace. That would be an orthotic, but the actual parts inside them are prosthetics. But yeah, I mean, it just amazes me that that's how far we've come, right? And just the fact that the patient, you know, is able to do that, and you'll see them post-op day one, and they'll be up and walking. But if nothing else, I hope that gives you a little appreciation of how much pain they're in when they get up, right? They literally just took a lathe, that angular kind of pointy thing, and just jammed it down in to make a hole to put the femoral component down in there, right? And think about it. When they put that acetabular component in, it's not like they're like, oh, well, you know, let's numb the bone up before we just shove a, you know, DeWalt drill up in and drill those screws to hold it in place. Those are completely placed there because that's the way it holds it in place. Just amazing. Are there any questions about that surgery that I might be able to answer, or at least get the answer for? Pretty cool. You want to go see one? Exactly. Go see one live if you can. If you get an inpatient rotation, ask if you go see them live. Even if when you get, like, when you actually get full-time employed, it's really good to go watch these surgeries because it helps you give an appreciation for what the patient's going through, right? If you have somebody that's got a total reverse shoulder, go see one of the total reverse shoulders. Those are wild. The fact that they switched the shoulder around. So that now the actual concave part is on the shoulder and the convex part's coming out of the, you know, the scapula. There's all kinds of things that can happen that are really cool with the body. And the heart transplants and those type of transplants, if you can get in on those, are really amazing. Or open heart surgery, because you just sit there going, holy crap, that's the person's heart. And when you see them and see how the heart is a lot tinier than you thought it was. It's not as big. It's not like it's this huge pumping thing. You think it would be this huge thing. In reality, it's a little bit smaller than the size of your fist. Any other questions? Pretty cool. All right. If I don't have any other questions, that's it for me today. So my plan is I'm going to do this today. I think tomorrow I've got the knee lecture in this class, and then we have some thorax stuff to do. And then when I get back to Las Vegas on Wednesday and Thursday, I'm going to go through manual muscle testing of the knee and manual muscle testing of the hip. And then the next week, we're going to go over hip, range of motion of the hip, range of motion of the knee. So I kind of have it broken up that way. But that's it for me today. I appreciate you guys coming in. Yep, got to roll out. Have a good day, guys. I will try to be. I can't guarantee it. I will try to be. All right, get out of here. Thank you, guys. Have a good day.